presentation by Stefan Frankel on models for personalized medicine, digital medical twins beyond data aggregation.
Yeah, so thanks for the introduction and welcome back from the coffee break. I hope you all enjoyed your coffee. And now it's my pleasure on behalf of the consortium behind Models for Personalized Medicine to actually present some of the work that we did over the past several years, actually to try to bring research ideas into the clinic and directly to the patients. And this is not, yeah, now it's working, okay. So what we did at the University of Leipzig, we formed a regional network of different partners. So we integrated, of course, the university clinics, different departments there, as well as 8 different SMEs, all located in Saxony, because we tried to have a regional network that actually can cooperate very directly and very easily together to actually address several issues we saw in the integrated care for head and neck tumor patients. So our aim is to actually improve this integrated care, for instance, by improving the interoperability of existing products, widening their field of application, or even develop new, let's say, prototypes of assistance systems and functions where we identified gaps or unmet needs in the treatment chain. And we are focusing on various stages during the cancer treatment, starting with diagnostics. There we focused on integrating molecular diagnostics, molecular biomarkers more seamlessly into the clinical routine, because this is not working quite well yet. Then we also focused on decision support. That's where we integrated a lot of predictive models, a lot of different decision support, AI-based and evidence-based models. And also we are focusing on actually having a more concise, a more precise presentation of information during, for instance, the tumor boards where the major decisions for cancer patients are made. And we try to optimize the workflow there as well. Then, of course, we are trying to improve patient education, because we see that patient compliance is one of the major factors that also influences the outcome. So we try to actually educate the patients on different options, different therapy options, and what they need to expect from the treatment, what their quality of life might look afterwards, before the actual decision is made. And then, of course, we are also supporting the actual tumor treatment. This might be radiotherapy, chemotherapy, or also the surgery. And then we also target long-term care, because usually the patients have a very long record in an aftercare situation, where we try to integrate patient-reported outcome measures structurally into the clinical data and match them with clinical data to actually improve the situation for the patients even after the primary treatment. Well, maybe let's go back. All the different applications that we've developed there, they are all focused on a very specific context. So they're all tailored towards the needs, the user needs in the current treatment situation. And they should actually integrate into the existing clinical workflows as seamlessly as possible. That's the goal. And we try to develop these in interdisciplinary teams, so we always have clinicians on board, we always have a medical researcher, biomedical researchers on board, and also software engineers and ethics patients, and also experts for regulatory issues, because if we try to get this to the market, all these factors need to be considered. And the actual major hurdle for most of the SMEs that focus on a very specialized functionality or specialized part of software is actually that in the real clinical setting, the IT ecosystem is very, very complicated. So in our university clinics, for instance, there are over 100 different software systems storing patient data in just one clinic. And there are a lot of different standards and so on. So hence we focused on developing We call it a digital medical twin. You might call it a virtual twin, a middleware, a backend, however. The idea is to actually integrate all the case-related multimodal data of a patient treatment. So the vision is to have a one-stop shop for all the applications to go to and ask for information on a given patient, and then they should retrieve the data there instead of having to link to several different IT systems. And how do we achieve this? Well, we are also linking it, of course, with clinical knowledge. So we are modeling clinical guidelines, institutional SOPs, as the guidelines are sometimes not specific enough, or even clinical pathways. And we're using the Web Annotation Data Model standard to actually connect different document segments, paragraphs, work steps in different models, and so on, with different data points, so we can interlink all the available knowledge that we explicitly model. And we try to rely as heavily as we can on established standards. So BPNN, for instance, for the processes, standard terminologies, FHIR, and so on. So to actually foster the interoperability of the different systems. And we, on the other hand, integrate also the case-related data. For the representation, we are using a resource description framework graph, as this is relatively easy to map to FHIR as well as OMAP, for instance. We can easily extend it to include new types of data, new linkage between different information entities. And for instance, we integrated the molecular diagnostics in cooperation with the ENT department and the research lab at university clinics, together with Qualitype and Biotype, both companies providing the lab system and also the analytics platform. And one of the nice things about having such a graph representation is that it actually eases the explainability of data we provide, or also abstracted derived information we provide with the systems, because they are linked back to the actual clinical findings. So this is one of the major issues of having an acceptance in the actual clinical routine, that you actually can explain where the suggestion comes from, or where the staging or whatever you provide actually originates. So how do we actually enhance the aggregation of data? So the idea is there are several different options. So applications might request simple clinical data from IT systems, then we provide it using FHIR, for instance, or using DICOM if it's image data, all the established standards, so we don't try to reinvent the wheel, of course. If there is already an interface established, then the systems can use it. But we also have different modules for checking, for instance, the consistency, or checking if all the needed data is available before we actually go into the molecular tumor board. So we are checking, is all the data available, is it up to date, stuff like that, just to avoid having to reschedule patients because some data is missing, things like that. We also, of course, calculate different scores, stagings. We have predictive models that analyze trends and stuff like that. And also we are doing cross-checking with clinical guidelines to see if the treatment options are in line with the clinical guidelines, or if there are any other options that might be available. And to do this on the fly, to actually being able to be dynamic with this, we define several modules. So we are not using one big model to answer all the questions, but we structured in very small modules that actually describe in a standardized way their required inputs as well as their possible outputs, which allows us to actually compile at runtime a call hierarchy of all these different models. And we can choose for each of the questions the model might want to answer, we can choose the best weapon we have. So let it be an AI method, or let it be a simple lookup table, or whatever is needed for the question. So for instance, a very simple example, if you want to know if surgery, for instance, is an option for treating the patient with this cancer, one of the required inputs might be, is it feasible to do an anesthesia with the patient? So there's another module evaluating the anesthesia applicability. And then this goes back to kidney status, looking up laboratory values and stuff like that. So we actually split the very complex question into simpler modules that we can combine on the fly. And one of the major benefits of this is also that the validation of the different models is way easier because it's a way more concrete question that we need to answer for each of the different modules. And we can compile those on the fly and then answer to the application what's actually going on. So this is a practical way of actually having a modular architecture where we can include new research results relatively easy into an existing ecosystem without changing all the different softwares and applications that might want to use actually the information. And from an applications perspective, the requests can be done requesting defined information or subsets of these, either with FHIR or GraphQL. Of course, the interfacing, as I already said, to clinical information systems is retained if there's already a link established. And of course, for research purposes, we also have a SparkQL endpoint to have very complex requests to the underlying RDF graph, but it's usually not used in the clinical setting, but more in research environments. And as one first application that we implemented is what we officially call a case explorer, but it's actually more of a Swiss Army knife. So the idea is to have a web-based application that is able, as you can see on the right, that is able to visualize all the different data that we have for a patient in different contexts and adapt it to whatever context, clinical context there might be. So we are including images, documents, observations, and stuff like that. We will also try to have visualizations where we see actually the linkage between, for instance, an MRI image where there is a lesion and the actual paragraph in the report that describes the lesion in the radiological report. So you can switch between those without having to re-log into a different system and whatever. What is still in clinical practice still the daily pain of most of the clinicians. And of course, we also use it as a universal test tool for the backend because it uses mainly all the functions that we provide. So it's a very nice test tool as well. One of the pilot applications that we're currently finishing is an intelligent conference environment for the interdisciplinary tumor boards. So what's happening there is actually clinical experts from different domains get together to actually decide on the best recommendation for different patients. And usually not all the clinicians have a good image or have a good understanding of the situation of the patient, of the case. Sometimes they hadn't even seen the patient before. So what is usually done at first is a brief introduction of the patient. So an assistant clinician is usually preparing a sheet and is reading all the relevant information to the tumor board. We do this, we support this with a wizard-like, very structured introduction of the case where it's actually always the same, following the same structure, which makes it way more easy to get a brief overview of what's going on with the patient. And we do this in a single app, so all the different information sources are still in one app, no need to log into other clinical IT systems. And then after that, there's usually a very dynamic discussion phase where especially if the case is more complex, where the clinicians try to decide what might be the best way to do it. And for this case, this is in cooperation with the Voice Interconnect and the Gesellschaft für technische Visualistik. They are providing a system where audio signals are analyzed, and of course we support the standard voice commands to actually control the visualization, but it also analyzes the discussion context. So for instance, if the clinicians are looking at the MRI image and they start to discuss about a comorbidity that might be relevant, then a context-sensitive pop-up will appear without any manual interaction, actually showing a very brief summary of what's relevant for this discussion. So we hope to actually be able to automatically provide the information needed to streamline the discussion and avoid actually having manual interactions to look for different information in a different folder, document, whatever. We're trying to actually make it in a way that all the clinicians can actually focus on the clinical problem instead of having to interact with different systems. And of course, when a decision is made or a recommendation is finally made, we can provide a structured documentation of what information has been analyzed, has been shown, what the discussion looked like, and we can generate a report that might be forwarded to the clinical information system for storage and for documentation afterwards, again using HS7 FHIR. Then, of course, if there is a recommendation for a different treatment or for treatment, we need to educate the patient actually on the different options and on the expected outcome and the different risks and stuff like that. And therefore, we develop in cooperation with Ethicos and LAFX an interactive tool for the patient education. So now this is done based on pen and paper, actually. So if there is an interaction, if there is an anatomical discussion or an anatomical problem, usually the clinician tries to actually paint something on a white sheet of paper to actually explain the issue to the patient, which is not satisfying. So the idea or the goal is to increase the patient compliance with an interactive presentation of the different therapy options. This is done with 2 tablets. So we have a clinician's tablet with control functionality and a patient tablet that's actually visualizing a 3D avatar, as you can see on the left. And then there is a personalized guided tour of different viewpoints onto the problem that is prepared in beforehand. And then the surgeon or the clinician and the patient can actually go through this. And there are also, of course, options for manual interaction, adding different markers and stuff that is synchronized between the 2 different tablets to actually help the clinician to explain actually the problem and also to motivate the patient to actually explore themselves what's the issue and to ask questions if they have any. And of course, again, we can document what has been shown to the patient, what has been discussed, and so on. And we hope to improve patient education with this. Then for the therapy, I've chosen one of the nice examples from our intelligent operating room. As you might know and see on the right, in our facilities we have an integrated operating room for demonstration purposes. So all the devices are connected using the IEEE 11073 SDC standard. So we can basically read and write to all of the different devices. And we use the digital medical twin backend actually to adapt the configuration of the different medical systems and their behavior to the needs of this specific clinical intervention or surgical intervention that is going to take place. So what we are doing is, for instance, we compile a parameterization, so a setup for the different devices based on what's the order, who's the surgeon, what risk factors does the patient have. So a simple example might be you have a patient, you want to remove an adenoma, a transnasal, so you're going through the nose, and the skull base of the patient is really low. Makes it difficult actually for the endoscopic intervention to go through. That's why we automatically reduce the Shaver revolution limit to actually mitigate the risk of ending up damaging or ending up in the brainstem where we don't want to be during the intervention. So we try to optimize patient safety and also streamline the workflow. And what's currently happening in the OR is that the circulator is running around and trying to configure all the different devices from their experience. So they know it's this type of operation and might be this risks, and they try to remember all these things. We can do this explicitly, and we can do this with one button press. So there's one button press, and all the devices configure as needed for this specific patient in this specific situation. Then we also provide a short dashboard at the start of the intervention just to increase patient safety by just remembering everyone that there are several issues that might occur and several risk factors. Also in compliance with the WHO safety checklist that is usually performed before the start of the intervention. So we enrich this with patient-related data as well. Then we analyze all the workflows that we are seeing, all the data that we are seeing during the intervention. And we parameterize a model that's actually comparing the expected workflow with what has really happened during surgery. So we can identify, for instance, unusual situations, adverse events, stuff like that. and we can therefore objectify the actual report that is generated later. So we can assist in actually reporting what was going on in the operating room. Because this is now as well only available as plain text, and no one can later analyze it automatically or analyze it using AI methods or something like that. And there we have structured reports with other actual timestamps and stuff like that. And the Facon, a company, is a spin-off of ours. They've also developed different physical training phantoms for adenoma patients, in this case. And we can select, based on the data of a real patient, the most fitting training model for this patient. And we are using this as well to evaluate it in our demonstration OR. And we also evaluated the system on previously done OR recordings. And the next step will be to implement this in the clinics as well. And last but not least, I selected a clinical study that we are supporting with the digital medical twin in cooperation with the Department of Neurosurgery at the university clinics, where we assist pituitary adenoma patients. So it's usually a very long-lasting disorder with a very long treatment. And the goal was to actually have a quantifiable understanding of the correlation between clinical parameters, therapeutic measures, and the quality of life. So what we did is we acquire, or what we do still, is we acquire different patient-reported outcome measures by digital and paper-based questionnaires. There are around about 160 patients filling in the questionnaire per year. That's round about half of the patients that are actually treated, due to the fact that the questionnaire is really long. So we are very glad and very happy that the patients are willing to take this very, very long questionnaire. So one of the next steps will be to actually personalize the questionnaire as well and kick out all the questions that might not be relevant for this patient. But in the first step, we need to collect all these data to actually know what is relevant questions, what are relevant questions, and what can be omitted. And we combine this, for instance, with therapy-related data. So with the medication, it's hard to read, but on the right side, you may be able to see it. There we have a patient, and we list on a smart mirror display, we list actually the results from the questionnaire, so from the quality of life assessment, and we correlate it with the different medications, because these patients usually get some substitutes for different hormones. So it is very important to know and to actually fine-tune the medication doses for these patients to actually have a good quality of life, for instance, after the removal of the gland. And we also plan to integrate this into the consultations, the frequent consultations every week in the university clinics permanently. For right now, it's still a study, ongoing study. But the next step will be to permanently integrate this into the routine. Yeah, and this concludes actually my talk. Just one thing I want to say is we have a lot of very promising prototypes right now, and we are happy to have a funding from Saxony to actually hand over some of the most promising prototypes to the next phase and assist all these SMEs in actually bringing this to the market, getting the approval, the regulatory approval we need, so that we have some sort of sustainability with the project results for the project that ended in November last year. Yeah, thanks for your attention.
Thank you very much. I just have a very quick question. It's a curiosity. Well, I mean, we have heard this morning the big picture project.
Yeah.
When you see a project like this, how do you think it can connect with such innovation that you are carrying out?
Well,
if it does.
Yeah, of course. Well, there are several stages. So the first stage, what the big picture project does is actually collecting the data, enabling the development of new AI methods, and that's very important. But we shall not forget that there is a very big step that we need to do to actually bring this to patients, to actually bring this into different clinics, and not only like 3 selected clinics that are at the forefront of what's actually going on in research, but to bring it to kind of pathetic. Bring it to all the citizens, bring it to every patient. And there is a lot of like practical problems that we try to work on that are also relevant and need to be solved. And what we try to do is actually establish this platform so that it's way easier if someone uses the project we heard, the big picture project, and develops a new AI mechanism, we can pack it into a module and throw it into our architecture, and then it will be available to all the applications. So this is kind of the strategy that we are trying to follow with this approach.
Wonderful. I don't know if there is any question, a quick question, because otherwise I think we are a bit late on the schedule, so I would just proceed with the a word.
With pleasure. Just to give you a very practical example. Sorry. Absolutely important area, what we are talking about. An example from the clinic, postmenopausal breast cancer, left side, operated, irradiated, chemotherapy, everything successful, and the patient dies from sudden heart attack because a cardiologist was not involved in tumor board. So we run in Bonn studies which demonstrate that more relevant experts are involved in tumor board, better outcomes. So this is exactly what the colleague is talking about. So congratulations to this talk, excellent. So best practice award in key thematic area 2, that is health technology in connected and integrated care, goes to Stefan Franke, University at Leipzig. And the topic, very well elaborated, is models for personalized medicine, digital medical twins beyond data aggregation. Congratulations.
So the next talk, unfortunately, will be online because Dr. Margot Thiele had some issue with flights and train. So Margot, can you hear me?
Yes, we can hear you. Can you hear me?
Yeah, so I think
Okay, perfect.
there are no technical issues. And we are going to see codex for SMES, interregional collaboration for companion and diagnostics. Please.
Yes, thanks a lot. Thanks for the invitation. We would have been very pleased to join you in person indeed, but we just reached Frankfurt and then there was no way to come to Brussels, unfortunately. So I'm very sorry about that. So maybe you can just go to the next slide, please. Is it working? I cannot see it.
Can you see the slide?
Okay. Yes, okay. So, yes, I'm very pleased to give you a talk about our Codex for SMEs project. You see, it's an Interreg Northwest Europe funded project. And this abbreviation, Codex for SMEs, stands for Companion Diagnostics Expedited for SMEs. And the project is already running since 2017. It will be finalized in the end of this year. It will run until December. And we have really a strong objective within this project. Our objective is and was to improve the healthcare by enhanced adoption of personalized medicine in Northwest Europe and beyond, by establishing a network which supports SMEs along the value chain of companion diagnostics development. Next slide, please. Well, and I would like to take the opportunity to tell you a little bit about the background story and the reasons why we thought Codex for SMEs could be a good idea to establish. You all are aware about the benefits of personalized medicine. Olga already explained it as well. personalized medicine will lead to cost savings in public healthcare, and therefore will also drive the trend towards increasing implementation of personalized medicine across Europe, with really an increasing demand of companion diagnostics and diagnostics itself. And therefore, we thought the establishment of a network in the field of personalized medicine play an essential role to overcome barriers and hurdles for this implementation. And we take the opportunity to compare it with the example of companion diagnostics development. Please go to the next slide. Well, and you know, companion diagnostics are the enablers of personalized medicine. They really deliver the right treatment to the right patient after an initial diagnosis. And therefore, companion diagnostics are really an indispensable part of personalized medicine. Next slide, please. Well, and the personalized medicine market will really have and face a strong growth, and will therefore also drive the growth of the companion diagnostics and the diagnostics market. And we think, therefore, Northwest Europe SMEs and also SMEs from all over Europe, they are the diagnostic innovation drivers in this field, have really a strong potential to exploit this increasing and strongly increasing market. Next slide, please. Well, and in the development phase of this project, we, of course, did some research about the tackles and hurdles SMEs might face in this kind of field. And we all know that Northwest Europe is currently not competitive compared to the USA within the implementation of companion diagnostics. And it's not even Northwest Europe, it's all Europe. SMEs really have to overcome lots of burdens, although they really possess the skills, the knowledge, and the experience, but there is no structured way for them to find support. I just want to give you some examples here. You see here really a list of hurdles and barriers we noticed within the development of companion diagnostics. One major barrier are, of course, the high development costs for those kind of diagnostics. And in addition, the development process is very time consuming. And what is maybe also very important, the new IVD regulation becomes effective now, and therefore there are a lot of uncertainties for the SMEs, especially for SMEs. They have not the resources and the money to get really tailored support to develop their companion diagnosis in the right way, maybe. Can you go to the next slide, please? Well, and therefore, we thought Codex for SMEs might be the missing link here, and that was the idea to establish this network. And what is the added value of this Codex for SMEs network? The network joined forces through the ecosystems of 8 partner regions that is really providing a huge and a strong ecosystem, which is in that way able to identify the different needs and hurdles for individual SMEs in this field, and therefore can react in a very tailored way. So we have been able to provide really tailored support, especially for SMEs. The SMEs are really our main target group in this project, although we try to tackle or to comprehensive compile all different stakeholders along the value chain of companion diagnostic development. Well, and furthermore, we think that we can provide and foster the companion diagnostics and diagnostics development. And really result in the end for the SMEs, or have a result for the SMEs, that the time to market can be reduced and shortened. Next slide, please. I'm really very pleased that I can present you here our wonderful partner network, which is really interregional, I would say. We almost cover all Northwest Europe regions in this project. We have been a partner consortium of 12 partners in total. Some of them are already gone due to the long time period of this project, but in the moment we are still 9 partners actively involved in that project. And you see we have partners from Ireland, several regions from the Netherlands, France, Luxembourg, from Germany, and we had former partners from the UK, also from Ireland and from Austria. You have noticed the Biobank of Graz already within the first talk, as well as a project partner. So maybe you can go to the next slide, please. And this partner network is really characterized by its composition. So we are 6 business support organizations, 4 higher education and research organizations. For example, the 2 biobanks we have involved, the one from Austria and the other one from Luxembourg. We have a research infrastructure organization involved, and furthermore, an international organization under national law. And all of those project partners provide a really strong background in business development support, especially for SMEs within the life science sector. We are all very experienced to work with SMEs and to identify really their specific needs in this field. Furthermore, all of those partners provide an access to experts on regulation, IP, investment, clinical studies, reimbursement, research, for example, in biomarker fields, and market analysis. Next slide, please. And this interregional partner network within Codex for SMEs provides really an effective support for SMEs within several different topics, within the business growth, the scaling up of their products and services, within the access to biobanks, within pitching opportunities in front of European investors or big pharma companies. My colleague Clara will later on present you really hard numbers and facts within our project we have already reached. Well, and in this way, we have been able to provide really a regional and interregional dimension of support. And this stimulates the collaboration among companies and stakeholders in different regions in Northwest Europe and beyond. Next slide, please. And as you know, the establishment of networks is, especially in this field, very time-consuming in relation to the time-consuming fact of the development of those diagnostics we tackle or we focus in this project. And therefore, as a consequence, long-term sustainability of this established network would be of benefit, and in generally of other synergistic established networks would be generally be of advantage. And therefore, we thought it could be a good idea to identify other synergistic, more broaden networks in this field. And we approached the Personalized Medicine Coalition in the USA and also the European Connected Health Alliance. And with both, we are became member as Codex for SMEs project. Furthermore, we have been working and cooperating with a couple of synergistic projects and initiatives in the past, for example, with the SALIS project or with another Interreg Northwest Europe project, Boost for Health. And finally, we have been able to sign 2 memorandums of understandings with another synergistic project within the Interreg Baltic Sea program. The project was called Big Biomarker Commercialization. And this project is already finalized. And finally, also a memorandum of understanding with the Council of European Bioregions. Next slide, please. And now I would like to give the floor to my colleague, Clara. She will provide you with more detailed numbers and success numbers we have been able to reach within this project. Thank you.
Yes. Thank you for your invitation. And now I want to go on to the operational part of this project and show you how we established a cross-regional ecosystem for diagnostics companies based on the existing capacities and skills and knowledge of our partners, as you have shown in the previous slide. So first of all, we wanted to help the SMEs to cooperate with different stakeholders, for example, with large companies, also to support the interdisciplinary cooperations between biobanks, other SMEs from other fields, research institutes and hospitals. And especially also the background of the clinicians are necessary for translation of innovative R&D to bring new solutions from research to market. And with this, we provided the access to experts of the diagnostics value chain and also to knowledge, for example, from our biobanks, and access to EATRIS Research Institution Network. Next slide. So to implement this value chain, we followed a three-phase approach. So first, we started from the current situation with one solution for all. And so in this incubation phase, we did first a gap analysis to find the needs of the companies to develop new products or to support them also to develop the new products and build, this network. Then in the acceleration phase, we started to develop different services and also to test them with the companies and bring them together with our biobanks, for example, to do biomarker validation. And in the growth phase, this was dedicated more to development of new business model and also to guide them to the regulatory and reimbursement hurdles. With this, we want to establish a Codex for SME solution to foster the personalized medicine throughout Europe. Next slide, please. So to empower the diagnostics SMEs with new business skills, we provided, for example, for the development of new diagnostics, biomarker validation services on different levels, for example, seminars, consultancy, and also the validation part, which is a huge package, for example. In this, they got vouchers for more than 100,000 euros to develop their biomarker, or let the biomarker be validated by our partner, Integrated Biobank of Luxembourg. We have also Meet and Match DX program, where so-called challenge owners, which are large companies from the pharma and medtech area, to that the SMEs can provide new solutions for them. Also, we have business growth programs with dedicated workshops on different topics, then translational and regulatory assessment, and also access to biosamples from patients. Next slide, please. So far, we supported more than 400 companies directly and indirectly with tailored events and workshops. We have also a huge map on our website where the companies, but also other organizations have the opportunities to upload their profiles and competences. And we also provide matchmaking events where they can meet each other to start new collaborations. Furthermore, we supported more than 54 R&D collaborations within the network. And also more than 90 SMEs were supported to introduce new to the firm products, for example, via sample access or regulatory and translational assessment, and also in the Meet and Match program. And finally, so far, 9 of SMEs are supported to introduce new to the market product via biomarker validation and COVID-19 research services. And this number will also increase during the ongoing project. So next slide. So as Margot mentioned, we supported basically SMEs from Northwest Europe, but we also went beyond them. And so far we have, of these 400 companies, about 10% outside Europe. The Northwest Europe part have been supported today. Please, next slide. So because our SMEs play the key role in our project, I want to give you some feedback we received and also our expert in frame of this Codex for SMEs project. So for example, the Integrated Biobank of Luxembourg helped SMEs to develop biomarker-based diagnostics through a validation service. And here the company Mediagnost sees that the best advantage of this project was to receive independent and objective data and evidence regarding our project development. And next slide. Next slide. So the European Infrastructure of Translation and Medicine, which provides access to a huge number of research organizations throughout Europe, did also a regulatory assessment. And in this case, the company was very happy to get this a better understanding of their product in regulatory terms, and also that they were provided with new understanding on how to proceed. Next slide, please. As I mentioned before, we had also this Meet and Match DX program, which was provided by Innovation in Health, former the EIT Health Germany. And this brings together SMEs with large companies and medtech companies. These companies are, for example, GSK, Medtronic, Abbott, and Thermo Scientific. And here we
Their fault? Oh yeah, to Margot. Yeah, maybe Margot, can you? There's a connection problem with the Clara. Can you?
Yes.
Finish the presentation?
Yes, I hope I can do though. Yes. I think Clara was just explaining the feedback we received from one company who participated within the Meet and Match program, and they have been really very impressed by how Meet and Match program secured the engagement with such large organization like GSK Germany, and identified the challenges they had. They said it was an excellent way for startups to obtain airtime with these people and with such huge companies. And just for your information, we have launched already a second call for applications, which will run until April. So still time for applications. So we are really curious about the new applications we will receive. Next slide, please. Well, and we, as mentioned before, we had as project partner the Biobank of Graz. They have been responsible to provide sample access for biomarker-based companion diagnostics development. And we had a company with the name Life and Soft, and they provided us also a feedback and said the biggest advantage is the capacity of Codex for SMEs to provide access to patient samples to facilitate the validation of early concept in the area of cancer research. Well, and with the next slide, please, I would like to finish our talk. And thank you for your attention. And we have been really very pleased to be invited. Thanks a lot.
Thank you, Margot. Thank you, Clara. It's a pity that there was these flights issues. We would have been very happy to have you here. Thanks also for this wonderful presentation, which really stresses how interregional collaboration and access to data can support small and medium-sized enterprises in the development of their innovation.